Hi there. My name is Mark Shanahan, and I am that fellow who is dressed inappropriately for the beach in the title card you were just looking at. I'm a reporter at the Boston Globe, and my guest today is Dr. Anthony Zeitman. He's my radiation oncologist at Mass General Hospital. He's also a professor of genitourinary medicine at Harvard Medical School and Mass General Hospital. And I really appreciate him being here. We're going to talk a little bit about a podcast that, with the help of a few other folks, I put together for the Boston Globe about my experience with prostate cancer at the age of, well, I was diagnosed at 47, I was treated at 48, which is young. The average age of diagnosis is 66, so I was quite a bit younger. And despite the fact that prostate cancer is super, super common, I didn't know anything about it. So we have a lot to talk about. And I'd like Anthony to, well, first I'd like him to tell me why I didn't know anything about it. I mean, I'm a frivolous guy, but I'm not a stupid guy. And honestly, I didn't know anything about prostate cancer. And considering how common it is, that's ridiculous. So, Anthony, could you talk just a little bit about sort of the ubiquity of prostate cancer, and why is it that a lot of men who should know don't know?
Hi, Mark. It's a delight to be here today. I will begin with the first question. Why did you, a smart 46-year-old, know absolutely nothing about prostate cancer? Well, it's written in your Y chromosome. You're a man. And men just are far less, on the average, body aware than women. Now, obviously, that's a sweeping generalization. But there's some truth in generalizations. And men just don't know as much about their bodies. They're not tuned in. They don't even necessarily seek to learn. You knew nothing about your prostate. What do you know about your spleen, Mark?
Maybe less?
Even less, exactly. But so men tend not to be aware, and they tend not to seek information. They also tend to hide from physicians in a way that women don't. We don't tend to be that good with our annual follow-ups. We're not great with screening. And this is an endemic problem, and it's a global problem. It's not just American men, it's men across the planet. So your lack of awareness it doesn't make you unusual. It makes you completely normal.
Okay, but beyond that, is there something about the nature of the disease that you can?
The second piece, of course, is that it's that you're driving at it's a down there kind of cancer. Women are happy to talk about breast cancer. They generally have an understanding of the way their bodies work. They're not afraid to talk about periods and their ovaries, and childbirth, I'm sure, makes them sort of far more aware of themselves than we are of ourselves. So there's a certain some shame that comes with talking in public places about our body parts that women simply don't possess. And I think as 20-somethings or teenagers, we weren't so ashamed. But with advancing years, we kind of bury all of that.
Right. And we should say that at stake here with prostate cancer and its treatments are big issues for men, like continence and sexual function, that this is not like, shoulder surgery, that just to put a somewhat finer point on it, that these are, as you say, with advancing age, these are things that men don't want to contemplate anyway. And so with illness, it becomes very difficult.
Yeah, I totally agree. I mean, it's amazing how you mentioned the ubiquity of prostate cancer. It really is ubiquitous. In fact, by the time we're 90 years old, most men actually do have prostate cancer. Now, it's not necessarily a serious form of the cancer, but they do have it. So it's part of growing old and being American, is to develop prostate cancer. Now, our job as physicians is to find the serious prostate cancers and select those men for treatment. And that's part of what early detection is all about, this PSA screen that we'll talk about in a minute. Now, women were so far ahead of men in this. Women have been advocating for breast cancer funding, breast cancer treatment since the 1960s and 70s. Men came very late to the scene. The advocacy didn't start until the 90s and then really didn't pick up speed until the 2000s. Sometimes it actually takes a brave celebrity to speak out. And women had their mammography was pushed ahead by George Bush the father. His wife had a breast cancer that was diagnosed by mammography. And later on, 2 decades later, it was actually Bob Dole and Storming Norman Schwarzkopf who had their prostate cancers discovered early through PSA testing. But again, it was the fact those brave men went public that helped other men to consider, maybe I should get my prostate checked out, maybe.
Well, and how long have we, because one of the first things that I did, because I knew nothing, was I raced to my computer to Google prostate cancer, history of men who have suffered from. And what I learned is that, there have been enormous advances in the treatment of prostate cancer in the last 30 years, but that doesn't mean that we've only started to treat it. For years and years and years, we were treating men with prostate cancer in ways that really were perhaps worse than the disease. Is that right?
I think that's true. I mean, up until the late 1980s, early 1990s, most men who were diagnosed with prostate cancer had pretty advanced disease. It was either really big in their prostates or it had spread to other parts of their body. And if they had surgery to remove their prostate, it was the end result was really devastating for many men. Incontinence was the norm, or very common, let's put it like that. Impotence was the norm after the old style prostatectomy. And radiation, which came in big time in the 1960s and 70s, again, wasn't so very accurate. Really wasn't accurate. And we used to, we treat the prostate, but we'd also hit the rectum and part of the bladder as well. And men could have consequences from that too. So treatment wasn't great. So men were unenthusiastic about finding a prostate cancer when the treatment could render them with these huge quality of life consequences.
Right. Now, so, but was that something that, so the first prostatectomy was performed in 1904, and it was pretty regularly performed for 80 years after that. And in every case, because they didn't know or hadn't bothered to find out where the nerves are, men who had that surgery were impotent afterward. Was that information that was, in other words, would I go in and say, I have prostate cancer, I need my prostate removed? They would say, you're going to be impotent? Or was that just like unspoken?
I think it was largely unspoken. I mean, those of the audience who are old enough will remember, if you had an operation back in the 1960s or 70s, I don't even know that you signed the consent form. And your time with the surgeon was very, very brief. It might have been a couple of minutes. And he'd pat you on the head and say, and always a he, I might say, he'd pat you on the head and he'd say, little problem, I think we'll fix it. We'll take care of this next week. There you are. And that will be the end of it. That certainly was the case when I was was training in Britain in the late 70s and early 1980s. The surgeons all had that kind of patronizing approach.
And how was it that, how did we used to, I mean, what you said was that it used to be that by the time you were diagnosed, you were pretty far gone.
Yeah.
That it was, and that's because it was, you had symptoms, and typically you were asymptomatic these days when it's detected. By the time you have symptoms, it's really quite involved.
Yeah.
My question is, how did we discover prostate cancer then, and how do we discover it now?
Well, then we discovered it because a guy would have just such severe urinary symptoms, or he'd cork off entirely, or you wouldn't discover it until it had spread to the bones and the man was in pain. So we used to see men just turning up in the emergency room with back pain, and that was the first they knew of their prostate cancer. And even the guys in whom it hadn't spread, they had pretty advanced disease, such that even when they had the surgery, so remember, it's a surgery that might leave them incontinent, would leave them impotent, and then didn't even cure them because it was too advanced. It was a sort of triple failure. In the late 1980s, this thing called PSA was discovered, and it's called prostate-specific antigen. Now, an antigen is just a protein that's discovered in the bloodstream, and it's a prostate-specific protein. And it appeared that in men with a lot of prostate cancer, the PSA levels were very high in the blood. So therefore, you'd think that if you work backwards, a man with a low level of prostate cancer would have a lower level of PSA, and a man with no prostate cancer would have a lower level still. It won't be zero because the prostate itself can make some PSA. Remember, it's prostate specific, not prostate cancer specific. So the idea developed in the late 80s that this could be a fantastic screening test to catch everyone's prostate cancer at an early stage. And it was picked up with enormous enthusiasm in the US. I mean, really enormous enthusiasm. And primary care physicians were pushed to get PSA tests on absolutely everyone. And what started to happen is instead of there being in America 60,000 cases diagnosed a year, all of a sudden, by about 1991, there were 300,000 cases diagnosed every year. And in retrospect, what was happening is we were casting this net and we were hauling in all the serious prostate cancers and an awful lot of the not very serious prostate cancer. Remember, I said that age 90% of us will have prostate cancer. Well, that's because it's a mixed bag. Some serious, an awful lot not serious. But in the early 90s, we couldn't sort out the serious from the not serious. So we just treated absolutely everyone.
Okay, so that's not good.
No, it's not good because you overtreat an awful lot of people.
Correct. So indeed. And when do people wise up to that?
Well, people. Let's put it simply. There's a transatlantic divide. You'll be aware that in America we're very proud of the fact that we're first to everything and we're early adopters of new anything. It's what we do. We're pioneers in medicine. In Britain, and maybe it's to do with the National Health Service, maybe not, but there's a much slower, more methodical approach. It's where's your evidence? No evidence, we're not going to do it. So we had this natural experiment that was going on two sides of the Atlantic. On one side in America, just about every man, it seemed, was being diagnosed with prostate cancer and treated for it. And in Britain, no one was being diagnosed and no one treated until they had advanced disease. But by the early 2000s, the death rates weren't too different on either side of the Atlantic. So people began scratching their heads and saying, how can this possibly be? Unless in the United States, we're over-treating an awful lot of guys for no benefit. And we began sort of thinking about this very earnestly in the early 2000s. And the evidence has now come in, and we now realize that there are 3 groups of guys with prostate cancer that PSA screening finds. There's a majority who have cancer so mild it should be left alone. There's another small group at the other end who have cancer so serious that actually even a prostatectomy is under treatment. And then there's a little group in the middle who actually really stand to benefit.
Well, I want to get back to that group because I suspect I might be in that group.
I think you will.
But before we do that, the question is, it is true. So as we think about screening and who should be screened and when they should be screened, we do know that some folks should be screened sooner rather than later. And who are those people?
Guys with a strong family history of prostate cancer. That's a father, an uncle, a brother. The current recommendations are for them to start screening at about 45. For the average man, it's somewhere between 50 and 55.
And what about black men, African American?
African American men, definitely, or also 45.
And
because they seem to biologically have a more serious cancer. They're more likely to have the more serious kind of prostate cancer.
And I mean, I guess, so my own father, as I write about and talk about in the podcast, was treated 15 years ago.
By me, I might add.
Well, that's right. But I didn't know that until we were well into into this process. But my question is, do you think that there's an adequate understanding either in the Black community or among folks who have an uncle, a brother, a father, grandfather about the risk factors? Because I mean, I gotta say, I don't think so. And I'm very keen to know, what I'm at risk for.
I agree with you. I don't think there's a widespread understanding. I think there are big moves being made in the Black community to promote men's health. I can't speak to whether it's being heard or not, but there are many community-based efforts, certainly within Boston, to do that. As for men with a strong family history, ideally, you as a patient should be onto that, but so should your primary care physician.
Right.
Now, the primary care physicians are in a very difficult situation. On the one hand, they're told, screen with PSA, and they're held culpable if they don't find guys with early prostate cancer. And on the other hand, they know that as a screening test, it's pretty imperfect. And they, over the last 20 years, have sent a lot of men to, not to their doom, that would be a terrible thing to say, but a lot of men to treatment that ultimately proved unnecessary with quality of life consequences. So primary care physicians are pretty confused. So our job as specialists is to kind of focus them. Black men, guys with a strong family history, those are the guys you need to push on.
Right.
The others, you can be far more cool about it.
Yeah. Well, I would like to give a shout out here to my primary care physician, Dr. James Morrill, who was mindful of my family history and yet was not immediately alarmed by a somewhat elevated PSA, understanding that, treatment is no picnic. And unless we know that you need it, you shouldn't get it. So this gets us back to those three types of men. The folks who have the sort of indolent, slow-growing, but detectable prostate cancer who might be 70, 75, and it would be surprising that if they didn't have prostate cancer. And then the folks who have a very, an astronomically high PSA and really do need some kind of treatment. I'm that third group. I had a biopsy after we waited for 18 months or 2 years looking at the PSA grow incrementally. Let's talk about what we do in that situation, because is it fair to say that what we do to treat men with prostate cancer really varies based on A, sort of the intensity of their cancer, and B, their age?
Yes, it does. So, it all starts with usually these days, an MRI and a biopsy. We look for the cancer, then we prove it's there. Now, if it's a really mild cancer. In the past, everyone would have been treated. I'm thinking through the 90s, through the 2000s, everyone was treated. A tsunami of treatment. And boy, I look back with no great pride at those years. I mean, I was trying to select men for active events, but I was kind of swimming against the tide. Men have been alerted. They've been told, you know, get your PSA checked. If you got cancer, get it treated early. Why not? It just took a very long time to prove that those indolent cancers were really as indolent as they actually are. And it almost doesn't matter your age. You might be in your 50s or 60s. If you got the mildest kind of cancer, you may never need treatment. You may never be threatened by this disease. Your sort of little group of cancer, the guys with the medium kind of cancers, they're the ones who I know. You know, you were 46 when you were diagnosed. If we just ignored it, let's say you'd never done any PSA screening, you lived on a desert island, you'd have been fine, probably until your mid to late 50s. And then you wouldn't have been fine. And, you know, mid to late 50s doesn't seem so old anymore, does it?
Correct.
So, no, guys like you need some treatment because sooner or later they're going to run into trouble. Now, it's a different matter if you're in your 70s and you have other health issues. And certainly when you're in your 80s. In your 80s, you have to, I believe you have to give me good proof that you need treatment.
Right. Well, and then it becomes a matter of playing defense as opposed to taking a more aggressive offensive. So I don't think my story is universal, but I do, based on the responses that I've received from this story, do think that it actually mirrors the story of a lot of guys, many of whom were maybe 10 years older than me when they went through it. But you would say, even as a radiation oncologist who has an interest in, you know, practicing the medicine and doing the work that you do, that for a guy who is 46, 47, 48, radiation may not always be, in other words, as I was thinking about possible treatment, I needed to think about my age in relation to what the treatment could and would do to me.
Absolutely. As a radiation oncologist, I would have recommended surgery for you at 46. And there are a number of reasons for that. I mean, the first is age 46, you want to know more about your cancer. And when the prostate comes out and is examined under the microscope, it's like looking into a crystal ball. I can see your future. I can tell whether you're likely to have been cured, good to know, or whether you're likely to relapse, good to know. That's important information for a 46-year-old. So that's number one. Number two, young men recover very nicely from the surgery. We haven't talked about the improvements in treatment over the years, but things have gotten much, much better in terms of urinary control and even recovery of your erections. So a 46-year-old is much more likely to have that good outcome. And the final reason I'd recommend surgery for a guy like you is because, you know, if I heavily radiate your prostate and you live another 40 or 50 years, as we would hope you would in this day and age, that's an awful lot of time to live with heavily radiated tissue. And there can be late complications of the radiation, 20 or even 30 years down the line. Something that doesn't happen with surgery. So young guys, the 40-somethings, the 50-somethings, I steer towards surgery or no treatment at all.
Well, but okay, that's interesting, and that is what I heard, and that is what I did, and the outcome has been good. You know, I do always wonder here as I sit in my mid 50s, had I done nothing, where would I be?
I think by now we'd be, had you done nothing, your cancer would have slowly grown. I mean, you were not, a lot of guys feel when they get this diagnosis that they're on the edge of a cliff and about to just fall into the abyss. That wasn't the case. It takes years. But by now, you know, whatever it is, 10 years later, you are yeah, that cancer would have grown. I could probably feel it. You might be starting to have some urinary symptoms. Yeah, and I will be urging you to be treated. Although your chance of being cured 10 years later will be lower than it was when you were actually treated.
Right. We haven't talked about the biopsy, which is the step in between the screening and
the screaming, did you say?
The screaming, good one. Listen, I was told by somebody at the Globe who'd had this procedure done that I should maybe back off the sort of terror-stricken feeling that I had, because we don't want to discourage men from getting the biopsy. But let's be honest, this is not a procedure that you want to have done.
No, it's pretty awful, it's awful for multiple. I mean, I'm being honest here. It's awful for multiple reasons. Number one, just because of where it is, you know, it's an area of your body that's never been impaled before. I mean, we've had IVs and we had a little minor surgery, but no one's ever stuck a needle into that before. So it's a kind of shocking and unusual sensation. And
it's that sensation 12 times.
Yes, it's not just once. It's again and again. And it was just 12 times in your day, Mark. It's often more now. But for everyone out there, there are new techniques to anesthetize the prostate that really will, though your experience may be repeated, because anesthesia isn't always, local anesthesia isn't always complete. Chances are, if you were to have a biopsy in 2020, it will be a less gut churning experience than it was for you back then.
I enjoy talking about my biopsy. The people that I talk to about it don't enjoy it quite as much as I do. But before we leave this, we should say, why do we take 12 pieces of our prostate? I mean, we do that for a reason.
Yeah, I mean, the prostate, is a relatively large organ. It's always said to be the size of a walnut, but walnuts vary in size. It might be the size of a plum, or in some guys the size of an orange, or in some guys as small as a grape. But when you take a biopsy, you're just taking one tiny little sample of one area, and it isn't necessarily representative. You have to take biopsies from multiple areas to have a reasonable chance of finding a cancer. And if the cancer is very small, it may be like finding a needle in a haystack. Mm-hmm. I will say that nowadays we can use MRIs to more accurately choose an area to target for biopsy. So I think the biopsies have improved. The pickup is much better.
I also like to make the point that, prostate cancer is common, but it's also eminently treatable. Yeah. With the caveat being when it's detected early. Yeah. Can you just talk about, there's some people out there who may be, feeling very anxious and newly diagnosed or whatever. This is in the sort of pantheon of awful diagnoses. It's cancer, but it is treatable.
Yeah, it's very treatable. It doesn't matter how advanced your prostate cancer is, it's still treatable. So, I mean, in the olden days, meaning not so many years ago, maybe 30 years ago, if a guy turned up with cancer that had spread to his bones, yes, we could help him for a year or two, but chances are he'd be in deep water in short order. These days, a guy who presents in that extreme situation with cancer everywhere is likely to live 6 years, 7 years on average. That in itself is remarkable. And that's the worst case scenario. For most guys who have earlier prostate cancer, they're either not going to die from it or they're going to live with it for decades. I've seen 4 or 5 men this morning who are in their 2nd or 3rd decade with prostate cancer. You compare that to lung cancer or, RBGs on our minds, pancreatic cancer. These are swift killers. I'm not saying prostate is not serious. It is serious, but your life expectancy is long. It's not short.
And can you talk about, we mentioned earlier, at some point you begin to play defense. because you can't sort of proactively or aggressively take the thing out. It has either eclipsed the margin of the prostate, or it is metastasized and it's in the bones or whatever. I had to take some Lupron. I had to do some hormonal therapy, which is something that a lot of men don't know a lot about, but do have to confront in relation to prostate cancer. I don't know if it was a uniquely unpleasant experience or if it was a sort of this is the experience, but it was awful. Can you just explain to me what is in the context of prostate cancer treatment, what is hormonal therapy and why do we do it?
Well, there aren't too many urologists who've won Nobel Prizes for medicine. In fact, there are two. But one of them is a man called Charles Huggins, who back in the 1940s demonstrated that prostate cancer is what we call hormone dependent. That means it is fed by the male hormone testosterone. And he demonstrated that if you remove the source of the testosterone, the testicles, a man with very advanced prostate cancer could feel miraculously better very, very quickly, literally within days, and could live 1, 2, 3 years. It was a remarkable advance in our understanding. And that's what used to be done until about the 1980s, when medications such as this one you mentioned, Lupron, came along. And these are medicines we can give that switch off the production of the male hormone testosterone. So it's a bit like having a menopause. So women, when they go into menopause, their estrogen levels slowly decline through their 40s and 50s. They have hot flashes. They lose interest in sex. They gain a little bit of weight around the middle. Their bones thin. They get osteoporosis. That's what happens to 50% of the population. For men who we give, we shouldn't even call it hormone therapy. It's anti-hormone therapy. We're switching off the hormone. It's like menopause, except their hormones crash. They don't come down slowly, they crash. We give you the shot, and as you will remember, within a month, your hormone levels were in the bucket. So you crash into a kind of menopause. Hot flashes, you may gain weight, your interest in sex will just fall off a cliff. And I mean, for many people, there's a spectrum of experience. There are some old guys in their 80s for whom this is no big deal. You have a few hot flashes, your interest in sex has long ago evaporated, it's no big deal. Younger guys often really hate this treatment because essentially what we've done is we've castrated you. I mean, it's a reversible castration, of course, but that's what we've de facto done. Yeah. And you know, it's the, if you think about it, it's the opposite of what Roger Clemens and all the baseball stars did. They used to take testosterone to pump up and bulk up and feel strong. This is the reverse.
Right. I actually, yes, I became a very, I mean, euphemistically they say mood swings, but this was beyond mood swings. I had just a terrible temper, and I would get very angry for no reason at all. And sometimes I would cry, for dumb reasons. So, you know, anyway, I guess, you know, it's so interesting to hear you talk about screening. You know, how many cancers are there where you can take a blood test to detect the possible presence of, and how many cancers, you know, are, you know, we know what they eat, what it eats, and that we can deprive them of the food that makes it grow. You would think that given those two things, that prostate cancer would be super easily detected and super manageable, and yet it's kind of insidious and very difficult to deal with.
Yeah, I would actually say I actually think it is kind of super manageable. You know, even the guys with very advanced disease who have to start hormone therapy, you know, we now have first-line hormone therapy, and there have been so many scientific discoveries that we have a second-line hormone therapy, a third-line hormone therapy. We've really learned how to fiddle with your hormone system to get your testosterone down as low as it possibly can be. And that's how we've squeezed out the life expectancies of men, even with very advanced disease. Oh, that's, I think, one of the most optimistic things about prostate cancer. I once said in Germany, the funny thing about prostate cancer is how hormone dependent it is. And then some elderly German professor got up at the back and he said, "There is nothing funny about prostate cancer." And of course, he's absolutely right. I didn't mean funny, ha, although he took that literally. But it is a curious thing about prostate cancer that we've taken advantage of. Same is true with breast cancer. Women are put on medications such as tamoxifen to fight back their breast cancer, also a hormone-dependent disease.
I wanted to ask you about the genetic component because, you know, the BRCA defect. In the case of men with prostate cancer, I have a 15-year-old son who I worry about, his grandfather, his father. At what point, well, I mean, how sort of predictive can we be about this?
Well, you're absolutely right about the BRCA1, BRCA2 story. There's this gene that was these genes that were discovered to predispose to breast cancer. Of course, needless to say, they were discovered 20 years earlier for breast cancer than for prostate cancer, just because we were so behind. But it turns out those same genes may be causal in some of the early prostate cancers. So we do look at guys. The reason I mentioned the fact I treated your dad was the fact that we're seeing a lot of father-son groupings. I treat a lot of fathers and sons, and pretty soon grandsons as well, I dare say. It's a reason for your son to be to have a certain vigilance, be screened probably from 40 or 45 onwards. 40 because you've got your cancer at 46. And there is a case for genetic screening. And I don't know that he needs to do this right now, but maybe at some stage in his 30s, it'll be worth running a gene panel, see whether he has any predispositions.
I do think, so I don't know what part of the program we're at here, but we had a number of people who called, no, they didn't call, a number of people who submitted questions that, you know, who may be newly diagnosed or maybe at some point along the way. We should say that Anthony is here to talk generally about prostate cancer treatment, the effects, etc., not really available to treat you in this context right here. One thing I wonder, you know, what would you say? What is a bit of advice for the newly diagnosed, from the perspective of somebody who has seen folks walk in your door who are completely at their wits' end and don't know anything about this disease? What do we say to those folks?
The first thing I would say is unplug your computer. Dr. Google, who is the commonest source of referral to my practice, is not always authentic. If you plug in prostate cancer, you will fall victim very quickly to Google's search engines, to advertising, to charlatans and quacks, to people advocating one treatment or another treatment. It's a dangerous place. There are some wonderful websites which give you really useful information on prostate cancer, but there's an awful lot of rabbit holes down which you can go and actually be misled. So that's number one. Number two is stop. Do not make any decision. None at all. Take some opinions. Chat with your primary care physician. The impulse is to get it out. That may well be the wrong thing to do, either because the cancer is too advanced or because you don't need any treatment at all. And you'll be leaving yourself with long-term consequences. So that's my advice. Unplug the computer and stop. Take a breath.
Yeah, I mean, I guess that I feel like, as somebody who really went through the ringer with this thing and didn't know anything, that, you know, the computer was somewhat helpful to me in terms of, you know, I tried not to dwell too long on those folks who said that if I ate an enormous quantity of habanero peppers or shark cartilage, I was going to suddenly, well, the habanero peppers, according to some people, it causes the cancer cells to commit suicide, to actually kill themselves. And I thought, that doesn't sound right. So I understand what you're saying. On the other hand, there are reputable websites that have actual information that was helpful to me to do the second thing that you talked about, and that is to go slow and to be very deliberate. And this gets back to your earlier comment about, in the early days of this thing, we didn't go slow. We saw an elevated PSA and we were marched right off to a biopsy, which of course, more often than not, will find some sort of prostate cancer, often a prostate cancer that won't kill you. So I think I agree mostly with what you're saying. The other thing I wanted to ask you is, so as I sit here today, I have a
well, actually, Mark, my advice is not to really to unplug the computer, but let your wife do the research for you.
That's good. But as I sit here, however many years out, I have a negligible PSA.
Yeah.
And people can read the magazine story or listen to Mr. 80%, the podcast, which is available wherever you hear your podcasts. I still have to get a blood test. First it was 3 months, now it's 6 months. The question I have is, and so I'm very anxious because the truth of the matter is that my testosterone now is back, and boy, is it back.
Congratulations.
But I have a very robust, like I think it's 520, and I'll put my testosterone level up against anybody's, but it could come back. And that's why I need to continue to be tested, or have my blood test. In terms of like the survivability of prostate cancer, we've established that it is something that you can survive, but it's also true that you can go 3, 4, 5, 6 years and then have this thing.
Unfortunately, you can go 10 or 20 years and then have a recurrence. Now, the majority of serious recurrences, the ones that could result in a threat to your life, occur in the first few years. But we do still see patients treated in their 50s who relapse in their 70s. And we think, what the hell has this cancer been doing for all this time? Just sitting dormant. And why now? What triggered this? Right. And I mean, it's an area of real exploration. We want to understand. I mean, maybe these individuals had some kind of immune system that was holding the cancer at bay for decades.
Well, so what do we do in that case? What do we do for the guy who turns 60 years old, has been through the ringer 10, 15 years before? I mean, is that where we do some more hormone therapy?
Well, no, it depends. I mean, that PSA that starts to rise again, it's like a wisp of smoke. It means there's some cancer. It means there's a little fire burning, but it may just be smoldering incredibly slowly. Not necessarily a big conflagration. So we tend to watch it. We see what the PSAs do. If it's going up really slowly, it may never need to be treated. It's going up somewhere in between. We wait, because we don't want to start hormone therapy if we don't have to.
Right.
Hormone therapy, it turns out, is something that we can start later, and it's just as effective as if we started earlier.
And isn't it true also that the older that we get, the slower cancer grows? Is that fair?
Not necessarily true. Yeah, that's kind of out there. That's a street law, but I don't think that's actually true, unfortunately.
Okay, well, that is unfortunate.
But you're still young.
Well, and we should say that I learned during this process that there are former heads of state, the Prime Minister of France, for instance, who lived for years being treated for prostate cancer and perfectly adequately.
Yeah. I mean, he was, I mean, this is no secret. It's no French state secret. He was on hormone therapy for the greater part of his presidency. In other words, he had no testosterone, but still functioned perfectly well as a president.
And we haven't really talked about, we did talk about risk factors a little bit, or at least in terms of folks who are at risk. I mean, sort of proactively, are you a person who recommends a plant-based diet or a vegetarian diet, or is there any real evidence to suggest that, less dairy, that folks can do something about this ahead of time?
I've got to be honest, the evidence for all of these things is pretty thin. I will remind everyone who's been diagnosed with prostate cancer that they're more likely to die of heart disease, because that's what American guys die of. Even though they've got a diagnosis of prostate cancer and no diagnosis of heart disease, they're still more likely to die of heart disease. And the correlation between heart disease and diet is much stronger than between prostate cancer and diet. So I usually take the opportunity to remind guys to eat incredibly sensibly. And how do I define sensibly? I actually like the work of Michael Pollan, the LA Times science reporter, who's written a lot about getting back to real food. Get away from the processed stuff. Just real food. Less meat, more plants. But it doesn't mean no meat, and it doesn't mean all plants. I think it's good for your general health. Fights off the heart disease that actually threatens your life, and probably, if anything is going to do good for you against your prostate cancer, it's probably that kind of diet.
Right, and is this a universal? In other words, the stuff we're talking about today, I'm always curious to know about sort of the European perspective, because they're, let's be honest, smarter in many ways than we are. Is this, in terms of sort of masculinity and their willingness to talk about this stuff, but also in terms of how they view this, because, in England, for instance, PSA screening is not, it's not mandatory, it's not even strongly suggested. So, how is America in the context of both sort of how we think about prostate cancer and how we treat it? Are we mainstream?
When I first came to the United States, which is now over 30 years ago, everyone was being diagnosed with prostate cancer and everyone was being treated with surgery or with radiation. In Britain, where I trained, no one was being diagnosed and no one was being treated unless they had advanced disease. Now, clearly, both these philosophies can't be right. Either one or the other is right, or there's some mid-Atlantic approach that makes real sense. And the mid-Atlantic approach, actually, it isn't really mid-Atlantic, it's Canada. The Canadians got it right. They slow walk screen. There is benefit to screening, but it's got to be selective, it's got to be targeted. There's no harm knowing you have prostate cancer, so long as you don't get unnecessary treatment for the mild kind.
Right.
That takes all the harm out of the bucket.
Yeah.
So Britain is moving, I won't say it's moving towards screening, but it's moving towards case detection in a targeted fashion.
Yeah, that's interesting.
So it's heading towards the state, and the states we've pulled back from our mass treatment of the 1990s, and we're going to meet in Canada.
You know what? We just may. All right. Well, listen. I think we've reached our 45 minutes, and I find this all so very interesting, and I'm honestly not a terribly curious person. So I don't know what it is about prostate cancer that maybe just that I got it, but the fact that I don't know or didn't know anything about it, and I think that it's so important that people do. So I really appreciate you taking some time and chatting with us. And I would encourage folks to read the story in the magazine, listen to Mr. 80%, which is a podcast from the Boston Globe, and PRX, which is available on Spotify and Apple and the Boston Globe. It's interesting, it's funny, it's scary, it's all of those things. So Anthony, Dr. Zeitman, thank you so much for taking some time today.
Absolutely my pleasure. And I'm actually going to advocate for your podcast as well. I thought it was a ripping listen. I've only listened to the first three episodes, but I thoroughly enjoyed it. It's beautifully put together. Well done.
Wow,
That's a real service for men, buttoned up men.
That's great. And
they're let it all out.
Right. And their partners.
And their partners, yes. Right. Absolutely.
Okay. Thanks so much to everybody for listening and watching, and we'll talk soon.